Hi, I'm Chris Kahn, your friendly neighborhood EMS medical director. Today I wanted to talk to you about stroke recognition. Now, sometimes it's really easy to recognize a stroke. Someone who's completely flaccid on one side of their body is probably having a stroke. And we don't really need a lot of help figuring those out. But we also know that sometimes it's trickier. And that's why we're going to talk about it today. We've actually also been doing some information on stroke recognition via telephone with our dispatchers and call takers. So you may be seeing a bit of increased information coming through in CAD notes related to their enhanced awareness as well. The reason that we're focusing on this is that stroke can cause really serious long-term permanent disability, but it's also something we can fix. Not every time, but we have a chance. If we can get patients, we recognize their stroke quickly, we get them to the definitive care quickly, and we get them that treatment, then we have the opportunity to greatly minimize the amount of disability that they have, or in some cases, prevent it entirely. That's pretty cool. And that's why we're talking about this today. So you remember that stroke happens either when a blood clot gets into some part of the brain and blocks off blood flow, or when you have a burst vessel and suddenly you're having bleeding in the brain. And that causes vasoconstriction and causes part of the brain to not get the oxygen and fuel that it needs. So generally, stroke is something sudden. Right? We think about a stroke of lightning. It's fast. And that's what strokes are too. You have a sudden loss of balance, or sudden loss of vision, or sudden weakness or numbness, generally just on one side of the body. So let's talk a bit more about those sudden onset symptoms. But keep in mind that not everything is easy in real life. We all get that. You can have a stroke while you're sleeping. And if you have a sudden onset of symptoms, but you weren't awake for it, you will never know if those symptoms actually started suddenly. So when someone goes to sleep and they're totally fine, and then when they wake up, they have symptoms that could be consistent with stroke, we're going to call that a stroke. And that is how we are managing the whole timepiece of it. So anyone with sudden speech problems, sudden weakness, numbness, paralysis of the face, the arm, the leg on one side of their body, with sudden loss of balance or coordination, sudden trouble seeing in one or both eyes, sudden severe headache, admittedly without a known cause, right? This is not I just got bashed in the head with a stick and now I can't move one side of my body. Now that's not stroke, that's major trauma. And I recommend avoiding that. But we're talking about those stroke symptoms that we're going to go to policy, or rather protocol S144. Now we use a mnemonic in the hospital that's be fast. And it's really the stuff we've already talked about. B is for balance, so sudden loss of coordination or balance, or they're just not walking quite right, they start falling over to one side whenever they walk, that sort of thing. E is for eyes, and that's going to be sudden loss of vision in one or both eyes. Because of how it's wired up here, you can actually have both eyes go out. Or sometimes you'll have half of each eye go out, like you can see okay to the right, you can't actually see anything on the left, or vice versa, of course. And that hemianopsia, that lack of vision on one side, is very consistent with a stroke. Sometimes it's just that you get double vision or blurry vision. F is for face. Facial droop is sometimes really obvious, and sometimes it's not. Sometimes honestly we don't always agree. Yeah, they got facial droop. Yeah, I'm not convinced. And that's okay. But if someone who knows that patient says their face looks different, we're going to call that a facial droop. A is for arms. And this has to do with not just, hey, one side is floppy and it's just not working, but also pronator drift, right? So this is when we have them stick their arms out, and we're supposed to have them close their eyes, and one side just falls down. Or even not quite that obvious, but you try to have them hold it up for 10 seconds and it's just sort of slowly drifting down and they can't really maintain it. That's a pronator drift, and that's a sign of stroke. S is for speech problems, and sometimes that's the more obvious garbled or slurred speech. When you're trying to stroke and it's just doesn't quite make sense, and that type of dysarthria generally is simply because the muscles that help control your tongue, your lips, your vocal cords, everything that makes the sounds, those just aren't working right. But you can also have expressive aphasia, and that's when the muscles are working fine, but the part of the brain that translates what you're thinking into the words that come out of your mouth, that's not working right. And that could be something like, "Are you having a headache?" And they respond, "Water. Orange." It's like, well, that doesn't make any sense. But that's the type of thing that can sometimes happen when your wiring in the brain is getting messed up by a stroke. Now, looking at our protocol, S144, when you pull that up, you'll notice stroke is a BLS emergency, right? The only two ALS skills listed there, one is to place a large bore antecubital IV. 18s are good, a 20 is fine, wouldn't go smaller than that. And that's because these folks they'll typically need CT angiography, where we're going to inject contrast in through that IV and take pictures through the CT scanner as the contrast fills up their blood vessels. See if the blood vessels just aren't filling properly. And we need a large bore antecubital IV for that. The other is to give 250 mLs of saline as needed to keep their systolic blood pressure at or above 120. That's it. Recognition of hypoglycemia is a BLS skill. Giving glucose is a BLS skill. And frankly, one of the most important things is to get them quickly to the hospital, which is absolutely a BLS skill. So things that will help us. One is having a witness, someone who knows this patient and can explain what they saw, why they called saying, "I think this person's having a stroke." And if we can't get them to the hospital with the patient, then let's make sure we get their phone number and tell them to answer that call from the unknown number, because that might be the neurologist or the emergency physician getting some of that additional history. History that helps us in the hospital, and obviously all history helps us, but some things in particular are if that patient has ever had a stroke or a TIA, transient ischemic attack, mini stroke previously, if they are on any antiplatelet or anticoagulant medications, blood thinners, if they've ever had bleeding in their head or surgery on their head, and then of course their last known normal time. Time of onset is good to know, but it's also one where they last known to be normal. And those aren't always quite the same thing. Like, hey, they say the symptoms started at 2:30, but they weren't really looking at a clock, they weren't quite sure. The last time I saw them and they were totally okay was 1:30. Then we're gonna have to use that 1:30 time to calculate sort of what window they fall in, whether it's safe to give them certain medications or do other interventions. We absolutely need that last known normal time. And that really is most of what stroke recognition is about. Looking for sudden changes that usually affect just one side of the body, and then acting rapidly. Because again, the sooner we figure out someone's having a stroke and the sooner we can get them to a stroke center where they can get the imaging they need, get a definitive diagnosis, possibly get clot-busting drugs or a catheter that's threaded up into the brain to pull a clot out, that sort of thing, then the less long-term disability that patient is going to have. If that means transporting via the BLS unit because that's what's available, that's totally okay. Because again, the only real ALS side of stroke is placing that IV, which we can certainly do in the hospital as well, giving fluids if needed if they're hypotensive, which in this case is asystolic below 120. And in a few patients, they may need airway management. Those folks, however, are probably so severely affected that they're not going to be going straight to the CT scanner. They honestly may not qualify for some of those stroke definitive treatments. So don't be afraid to harness the power of those BLS skills. Let's get those patients to the hospital as quickly as we can. As always, if there's any questions, I'd love to hear about them. So please feel free to ask your BMO or send them up the chain. I think everyone's got my phone number and email address by now. So thanks again for your attention. I know it's not a whole lot of fun to sit here and have to stare at me talking to you, but I really do appreciate the great work that you do and your attention for the last several minutes here. Thanks again.